Half of Medicine Unit 1. My case is Mrs. M, a 60-year-old female from West Bengal who presented with complaints progressive breathlessness for 3 months with no orthopnea or PND, facial puffiness and pedal edema for 3 months, with decreased urine output for 2 months with frothy urine. There was no hematuria which is present. There was no history of chest pain, palpitations, syncope, no history of jaundice, hematemesis, or melena. She is a known case of diabetes on for 20 years on insulin and oral hypoglycemic agents. On examination, she was conscious and cooperative. Her pulse, she was tachycardic with a pulse rate of 120. Her BP was 140 by 90. She was tachypneic with a respiratory rate of 36. Her saturation was 84% on room air and improved to 100% when she was connected on BiPAP. She was afebrile. Pallor was present. There was bilateral pitting pedal edema with abdominal wall edema, and sacral edema was also present. Periorbital puffiness was present. There was no icterus, asterixis, lymphadenopathy, no bony or spine tenderness. Systemic examination, the respiratory system, there was absent breath sounds in bilateral infrascapular, interscapular, infraaxillary areas. Crepitations were heard bilaterally in all lung fields. Cardiovascular system was normal. Abdomen was distended. Flank dullness and shifting dullness were present. CNS examination, there was no focal neurological deficits. At this point, with her history and examination, the differential diagnosis that was considered for a fluid overload state, because of in view of periorbital puffiness, renal was considered as the first differential. The differentials were diabetic nephropathy, membranous nephropathy, amyloidosis, myeloma kidney, SLE, paraneoplastic nephropathy. For liver, decompensated chronic liver disease, cardiac, either heart failure, valvular heart diseases, and rare cause like protein-losing enteropathy or malabsorption syndromes. Her initial evaluation, her HB was 7.8 with an MC of 96 and MCH of 30.6. Her total counts were normal. Platelets was 1.74 lakhs. Her creatinine was elevated with 5.76 with a urea of 94. Sodium was 135 and hyperkalemia of 6.4 was present. Her LFT was normal for most except for albumin of 2.2. Her PTINA was not deranged. Her BBVA status was negative. Urine routine showed glucosuria, hematuria, proteinuria, and leukocytes were present. Echo was done, which showed a moderate pericardial effusion with no hemodynamic compromise and normal LV function with an EF of 57.2%. In view of her creatinine and her urea, further workup was done for CKD. Her Bund creat ratio was 7.6 with her EGFR was 11.5. A calcium was 7.68 with phosphate of 4.3. Magnesium was normal. Uric acid was 2.6. Her PTH was elevated with 221. There was hypovitaminosis D with 11.9. Ultrasound abdomen and pelvis was done, which showed a bilateral kidneys, which was normal in size with parenchymal changes. There was no features of obstruction, no HUN features. Minimal ascites was present. Her urine protein was 24-hour protein came up to 3.7 grams, which was in the nephrotic range. In view of her CKD and with her adult nephrotic range proteinuria, the etiology which was considered and based on our differentials, for further etiology workup was done. Her HbA1c was 5.8. And she had normal C3, C4. ANA was negative. Anti-PLA2 our antibodies was in normal, which was for membranous nephropathy was considered. Syphilis was negative. And her anchors were also normal. Serum electrophoresis showed a generalized rise in the GABA globulins. She was in the hospital. She was started on BiPAP for ventilation for her pulmonary edema. She underwent 3 cycles in view of her refractory hyperkalemia. She underwent 3 cycles of renal replacement therapy and albumin diuresis, and later she was initiated on thrice weekly maintenance dialysis. Pericardial paracentesis was not done as there was no hemodynamic compromise. In view of her normocytic normochromic anemia and her clinical picture, she had anemia of chronic disease. She was given 2 transfusions, 2 doses of ferric carboxymaltose, and she was initiated on erythropoietin analogs. She was shifted to nephrology for her maintenance dialysis. On admission, she developed a right-sided pleural effusion, which on initial evaluation was found to be exudative in nature. Pleural fluid ADA was elevated, but expert was negative. The cytology done showed atypical B lymphoid infiltrate was present. She was hence referred to pulmonary medicine for a thoracoscopy guided right-sided pleural biopsy, which showed focal lymphohistiocytic aggregates. Her pleural biopsy was done, which was negative for expert and MGIT. In her clinical scenario, primary effusion lymphoma was one of the differentials considered for her. Primary effusion lymphoma is defined by WHO as the large B-cell neoplasm, but with no detectable tumor masses. It can either be type 1, which is HHV8 associated, or it can be type 2, which is non-HHV8 associated. HIV negative and HHV8 unrelated effusion lymphomas primarily occur mainly in the body cavities. Clinical picture of effusion, chronic inflammation, or altered immune status in elderly where there is immune senescence, it creates an ideal body conditions for lymphoma genesis. The two types of PEL. The type 1 classically is HHV positive, where the phenotype is mostly plasmablastic. Type 2, which is HHV negative, it can present in the fluid overload or without fluid overload status also, but the phenotype is majorly B cell. Type 1 and to further talk about type 1 and type 2. In type 1, the clinical characteristics usually presents in a younger patient where there is either HIV infection, immunodeficiency, or organ transplantation. Type 2 classically presents in an elderly patient, can be HIV negative with other underlying medical conditions or fluid overload states, such as in our patient. The underlying immune status is usually immunocompromised in type 1, and it's mostly immunocompetent, or it can be an elderly patient with immune senescence. The etiology, as mentioned before, in type 1, it's usually a HHV8 infection. Type 2, it can be fluid overload, chronic inflammatory situations, or any underlying medical conditions like liver cirrhosis, renal dysfunction, or heart failure. The treatment regimens for PL include either a dose-adjusted EPOC regimen, which consists of etoposide, prednisone, vincristine, cyclophosphamide, doxorubicin, or it can be a chemotherapy with the classic CHOP regimen, which is cyclophosphamide, doxorubicin, and vincristine and prednisone. Prognosis regarding PEL, there is no definitive guideline for treatment of PEL per se, and even with the treatment, prognosis remains poor. Median survival in studies remain less than 24 months. The prognosis is further worsened by the performance ECOG status of the patient, concurrent if there is HIV, and if there is involvement of pericardial cavity in comparison to the pleural and peritoneal cavities. The disease involvement, if there is more than one body cavity that is involved, it is also another adverse prognostic indicator. Coming back to our patient, she had involvement of 3 body cavities, and for her, the plan is her final biopsy results are awaited, and based on that, to plan chemotherapy if there is biopsy proven lymphoma. If the biopsy remains inconclusive, then to again send for immune histochemistry and to constantly monitor currently for her TLS symptoms until her chemotherapy is initiated.
Just one doubt, does your clinical syndrome was of a nephrotic syndrome from your history and from your initial investigation? Does PL present with a nephrotic syndrome?
No, the nephrotic syndrome was most likely to be due to her diabetic nephropathy is the first differential considered.
Came with a nephrotic syndrome. This was kind of an incidental.
But during her stay in the hospital, she developed the right-sided malignant pleural effusion.
We haven't done a renal biopsy for her, right?
Renal biopsy, initially it was planned, but because of her clinical status, it could not be this thing. Maybe later they might.
And she's CKD for how long?
CKD recently diagnosed. 3 months history of CKD is present. 3 months prior, her outside report showed a creat of 1.9 was present.
1.9. Sure. Less likely diabetes because the fall in GFR is too rapid. But yeah, sure. I think you should look at case reports if there's any nephrotic syndrome with
PEL.
But doesn't look like.
There are reports of saying that it could be because of direct infiltration of the kidneys. It can cause nephrotic range proteinuria, but without a renal biopsy,
we cannot.
This thing, which is why I didn't include in that. Sure. Her fundus showed moderate NPDR. No, bone marrow was not done for that.
So you had some paraproteinemia also, no?
For no, there was just generalized increased rise in the gamma globulin. This thing, there was no specific band. In her, myeloma and sorry. No, for her, other than in her, there was only
Amyloidosis.
Amyloidosis. There was
No, we haven't.
We haven't done anything for the
amyloid. Prove or disprove.
No, PET not done. Yeah.
You said the fusion had atypical lymphocytes, and that's why calling it transient fusion lymphoma. But can't it just be a
reactive,
like a leukemia lymphoma?